Hi, it's Dr. Gabal, and I'm here today to talk to you about your pelvic prolapse surgery. And we're going to be talking about what to expect before, during, and after, as well as some of the risks and benefits of having the surgery. So by this point, you should have gotten your packet in the mail that does describe where to be and what time. And a lot of the things that I'm going to be talking about today are kind of repetitive from that packet, but I'd like to explain it to you verbally as well. So you should have an appointment with your primary care doctor about 2 weeks beforehand. And that is so that they can do an EKG, some blood work, make sure that your heart and lungs are healthy, and that it's safe for us to put you under anesthesia. If you have any heart issues or if you're followed routinely by a cardiologist, we may also want you to have clearance by the cardiologist so that we make sure your heart is in tip-top shape before we administer the anesthesia. And then for the week before, we ask that you have no blood thinners. That means no aspirin, Motrin, Advil, Aleve. Also in the packet, you'll notice there's some supplements that we ask you to stop in the week before because all those things can increase the risk for bleeding during the surgery. If you have a headache or anything else, then Tylenol is the only thing that's okay. If you're on a blood thinner like Eliquis, then your cardiologist or whoever is prescribing that medication will tell you when to stop that medication. Usually it's best to do it about 3 days prior to the surgery. If you're having a rectocele repair, which is the posterior aspect of the vagina, then the day before the surgery, you'll have a bowel prep. And this is not a horrible bowel prep like if you are going to have a colonoscopy. It's more just we don't want you constipated going into the surgery because it will be much more difficult after to catch up. So you'll do the bowel prep the day before the surgery. That should also be described in the packet that you've gotten if you're having a rectocele repair. And then nothing to eat or drink after midnight the night before. You'll present to the surgery center or to the operating room about 2 hours before the scheduled time. I'll see you there that morning, and the anesthesiologist will also meet you there that morning. You'll be completely asleep under general anesthesia, which is a good thing. And then the whole surgery is done through the vagina. Your legs are up in stirrups. I'm going through the vagina. I'm peeling the vaginal tissue away from the bladder and then also your uterus if it's still there. And then depending on what type of surgery you're having, if it's a native tissue cystocele repair, which means no graft, then I'm just going to find some good tissue on the sides, bring that together, and that pushes that bladder back up to where it's supposed to be. If we're doing a graft, which is usually cadaver skin, cadaver dermis, which is very safe and durable. It's been tested for everything. The reasons I might suggest that we use a graft would be if it's a recurrent prolapse, if it's a very large prolapse, if you are a heavier person. All of those things are risk factors for recurrence. And so then we will use the graft material, which is a stronger, more durable material to keep everything up in place. And that then I put under the bladder, I lift it up and I tack it up to these little ligaments called the sacrospinous ligaments, which are on the side of the spine, not on the spine itself. And then for a rectocele repair, if we're also doing that, I go on the back of the vaginal wall and I peel away the vagina away from the rectum, find some good tissue on the sides, bring that together, and that pushes the rectum back down to where it needs to be. So if we're doing all of that together, it's about an hour and a half, the whole surgery. If it's just a native tissue with a rectocele repair, then it might just be an hour under anesthesia. Normally, you'd be in the hospital overnight for these types of surgeries, especially if we're doing a combination of those things. The next morning, the catheter comes out, the packing comes out, and then you should be able to pee and go home the day after surgery. Once you go home, you should be eating, walking, peeing and pooping, doing all those normal things. You can walk around the house, you can walk up and down stairs, but 4-6 weeks, no straining, no lifting over 20 pounds, and nothing in the vagina, which we call pelvic rest, for 6 weeks. We'll send you home with pain medicine. And so, especially if we're doing that posterior, that rectocele repair, it will be tough to sit for the first 3 to 5 days. You will definitely need the narcotics, and you can drive once you're no longer on those narcotics. We also will be prescribing antibiotics for a week to help prevent an infection. And then stool softeners, because the narcotics can be very constipating and we don't want you straining to have a bowel movement. Then we normally see you back at 2 weeks, which is about when our patients are feeling back to normal. You'll follow up with one of my assistants, my PA or my nurse practitioner. They'll make sure that you're doing all right, and then do a very brief vaginal exam, make sure everything's healing up okay. And you'll continue with your limitations until you come back to see me at 6 weeks. I'll do a more thorough pelvic exam, and that's when I give you my blessing for you to go back to all your normal activities. And so what are the risks with this procedure? Everything in life is risks and benefits. There is a risk for bleeding. You will not require a blood transfusion. You will see blood spotting, though, from the vagina for a few weeks, so you'll need pads for that for at least a couple of weeks after the surgery. It may go on for 6 to 8 weeks as well. There is a small risk for an infection. Now, a lot of times we're doing these surgeries so that you can empty your bladder and bowels better, and that may decrease your risk for infection, but I can't guarantee that you won't have another UTI the rest of your life, because there are other reasons why you may still have the urinary tract infections. There is about a 10% chance the day after surgery that you are unable to urinate, and the catheter would have to go back in, and then you go home with it for a week. And most of our patients by that point are fine and able to void urinate on their own. And then there is a risk for recurrence with any of this type of surgery, just like a facelift or anything else. If you live long enough, everything sags. There's no way to prevent that. So we expect things to recur. We're hoping for this to last at least 15 to 20 years. But some people recur sooner, some recur later. And so there is a chance that you may require another surgery to repair what we've also repaired at this surgery. But all in all, if I'm making the recommendation for you to have this surgery, then in my hands, I believe that the benefits of the procedure far outweigh the small risks. Your insides will be back on your inside. It will be easier to empty your bladder, easier to empty your bowels, less of a risk for infections, and hopefully you just feel better overall. So thank you so much for listening.